everyone, and today we are going to talk about urea and electrolytes profile. This is now again one of the most commonly requested biochemical tests. Um, and like this one, of course, urea and electrolytes in combination with CBC or complete blood picture or full blood picture, whatever you can call it as, it is almost virtually performed for all the new hospital admissions. And of course, like in this lecture, we are not going to talk about all the electrolytes because they are too many. Rather, we will talk about some important electrolytes, uh, which again doesn't mean like the other electrolytes are not important, but like sodium and potassium are common electrolytes which are performed along with urea, and urea is mostly performed with creatinine, or what we call it as renal function test. And urea electrolytes are often used as a screening test in unwell patients. And of course, like whenever we do any tests like this, biochemical tests or CBC, of course, like that leads us um, to think about what other testings we must do for that specific patient. So first of all, like I will talk about the normal values, which again cannot be same in all the books. Rather, different books they give different type of normal values. Sodium, and they're quite easy to remember. So like sodium, their normal values are from 135 to 145 millimole per liter, or you can say milli equivalent per liter. But they are same things anyways, right? So potassium, normal values are 3.5 to 5.0 millimole per liter. Um, bicarbonate, sodium, potassium, they are also, and chloride, by the way, they are also called as magic fours. Like it is easy to remember them by remembering the number 4. But anyhow, like you can remember it like this way: 135 to 145, or 3.5 to 4.0 for sodium and potassium. Chloride, the normal values are uh, 94 to 104 millimole per liter, or whatever, like milli equivalent per liter. Bicarbonate, I will talk about when we will talk about with like acid base balance. Now, other than this, there are many other electrolytes, like phosphate is there, calcium is there, magnesium is there, um, so and zinc is there. So there are many others, right? When we talk about the urea, the normal values are basically um, 2.5 up to 7 um, millimole per liter. And now, like of course, like in many of the books, you can found the same value with milligram per deciliter. So that is like around 7 to 18, if we will talk in that values, of course. So that is the different thing. And creatinine, because I told you creatinine is mostly done in conjugation with urea. So creatinine with normal values in males is 25 to 90 units per liter. So I will write down males, right? And of course, like in females, of course, it is a little less because females have less muscular mass. So it is 10 to 70 units per liter, right? So like these are the normal values of the electrolytes in the patients, in the people, right? And now some easy type of concept I will give you. Okay, let's talk about the electrolytes abnormalities first. Electrolyte abnormalities. Now, as I told you, we are going to cover sodium and potassium in this lecture. So, of course, like as you know, when the sodium is too low, it is called as hyponatremia, right? So, hypernatremia is what? Low sodium ion electrolytes. And whenever the sodium are more, we call it as hypernatremia. Emia means blood, of course. So that is called as when there is high sodium, right? And same thing with this with the potassium. When the potassium is low, or it is called as hypokalemia. So it is when there is low potassium. Okay, and whenever the potassium is more, it is called as hyperkalemia. So it is like high potassium levels. What it means, like when the potassium is less than 3 millimole per liter, we call it as hypokalemia, and whenever it is more than 5 millimole per liter, we call it as hyperkalemia, right? So of course, like we can discuss them one by one. And first of all, we can discuss hyponatremia. Hyponatremia, right? Now, hyponatremia, overall things are not so difficult as it seems, because we discuss them, or we read them again and again, in starting from the first year in physiology. They teach us acid base balance, and then we come across these things again and again and again. um, Now, as we know, what is hyponatremia, right? When the sodium levels will be less than 135 millimole per liter, we call it as hyponatremia. Now, hyponatremia creates a lot of confusion, not just in medical students, but among the doctors also. So the first step in working out what is the causes of hyponatremia is to investigate whether or not the patient has whether or not the patient have the low sodium is a true finding or it's not a true finding. So again, like one concept is what, remember guys, there is something called as osmolality. Okay, serum osmolality. And now what is serum osmolality? Simply how much sodium or how much osmoles are there in the given fluid. We call it as osmolality, right? So the plasma osmolality or serum osmolality is basically uh, it depends on sodium widely. Okay, so when the sodium is less, the osmolality goes down usually, and when the sodium is more, the osmolality goes up. So this is very, very, very important, right? So remember, hyponatremia and hypernatremia are basically that are the disorders of water imbalance. So whenever there is hyponatremia, it means or it suggests like there is too much water in the extracellular fluid. Okay, whenever there is hyponatremia, it usually suggests that there is too much water in the extracellular fluid in relative to sodium content. Okay, and hypernatremia usually suggests too little water in the ECF relative to sodium content. What I'm saying, that sodium and water usually in the normal state they go side by side. So whenever there is hyponatremia usually suggests too much water in the extracellular fluid relative to sodium content. And the other thing is true for hypernatremia. Hypernatremia usually suggests too little water in the ECF relative to sodium content. So, see, what we have in the plasma or in the serum or in the ECF, we have like sodium, right? We have like potassium. Potassium is basically intracellular, but okay, we do have a little potassium outside. We have glucose. Okay, so these are solutes, which cannot freely move across the plasma membrane, and that's the reason like these are the one which contribute to the effective osmolality. Okay, so see, like you can say like there is a cell, and outside the cell there is ECF. Like inside water cell is ICF, and outside water cell is ECF. So of course, like because these things cannot move freely between the cells, so that's the reason there is some osmolality, which is like the ECF is maintaining. Okay, so I hope you understand, right? So what will happen, for example, like you have to remember the diffusion on osmosis thing. In this one, osmosis, of course. See, when there is, or you can say increased ECF osmolality, okay, what will happen? Like when the osmolality of the ECF is increased. So see, when the osmolality of the ECF is increased, what will happen? The fluid which is inside the cell will go across the plasma membrane, and basically it is going to move out. So motor moves out of the cell, right? And opposite true for example, when there is decreased ECF osmolality, right? Osmolality. So what will happen in this one? Of course, the water now will move. You can say into the cell, okay, into the cell from the ECF. Why? Because now the osmolality is less, and so the solutes, they are going to move. Okay, so that's the reason, one thing, remember guys, sodium is the main ion of the ECF, and potassium is the main ion of or the main electrolyte of the ICF or intracellular fluids. And that's why you can say the extracellular fluid volume is determined by sodium content. Okay, so sodium content, now sodium content is different and sodium concentration is different. Now what will happen, what I mean to say is, when the sodium decreases, the ECF volume will decrease, and when the sodium is in excess, the ECF volume is going to increase, right? So see how hyponatremia and hypernatremia produces sign and symptoms. Simply when there is hypernatremia, whenever there is hypernatremia, the water moves out of the cell. So what is going on in this case? The cells will be shrinking, shrinking body cells, right? Or on the other hand, when there is decreased ESF osmolality, so water will move into the cell. So what will what will happen? There will be swelling of the cells or the body cells, right? It can be brain cells, it can be any other body cells. So a very easy concept, guys. Not a hard concept to understand. Okay. Now, for example, I will talk about hyponatremia. And to understand hyponatremia, this one is a very best, you can say, table which gives the sign and like the causes of hyponatremia in detail. Okay. Now, like a lot of baseline knowledge is needed to understand this thing for sure. Like one thing is, uh, there is the secretion of ADH, antidiuretic hormone. What happens like whenever the body, uh, the ECF or the plasma volume is decreasing, so the body started producing, or there is dehydration, for example, the body will started producing ADH, and what ADH will do, it will keep on reabsorbing water as well as sodium ions, right? So that thing plays a role, and sometimes there are many conditions in which there is inappropriate release of antidiuretic hormone. We call it as SIADH, syndrome of inappropriate antidiuretic hormone. Okay, so when it comes to hyponatremia, what can be the causes? They are in front of you, and I already tell you what is hyponatremia means. Uh, so I gave you the concept of serum osmolality, right? For example, what happens in hyperglycemia or hyperlipidemia? In hyperglycemia, there is too much glucose in the ECF, so it can, what you can say, it can mislead you, because like in that case, serum osmolality will be raised. Okay, so simply, guys, you can see now, whenever anyone have hyponatremia, okay, so what we have to do is to check either the osmolality is low, and it is in vast majority of the cases. You can see, like when the high, like a true hyponatremia is when there will be hyposmolality, right? Because like sodium are the one which define the osmolality of the serum. So you can see all these causes are basically when there is hyposmolality. And in this case, this is the case when we take it as a real type of hyponatremia. Okay. um, so that's why whenever like we have hyponatremia, we see like there is hyposmolarity, there is iso, this is the serum osmolality normal values, or there is hyperosmolality. So the next most crucial step after this is to check the patient volume status, to find out either that patient is hypovolemic, eovolemic, or hypervolemic. Hypo, eo, or hyper. So simply, there are many causes. Hypovolemic patients like dehydration, diarrhea, vomiting, sweating, decreased intake of water. Eovolemic when the water status of the body is correct, and hypervolemic when someone is overloaded, like in ascites. There is extra fluid in the body. So first step, simply we check the sodiums. Second is to check the serum osmolality, and if the serum osmolality is low, it means like it is a true hyponatremia. Then we see either it is hypervolemic, eovolemic, or hypovolemic. Okay, and I already told you the story of ADH, right? Now you can see over here, whenever there is hyponatremia, because these are the smaller ones, so we are going to discuss this thing first. When there is hyponatremia or the sodium ions are less, so we check if the osmolality of the plasma is normal. It is isoosmolar or it is between 280 to 295 milliosmol per kilogram. What can be the causes? See, it could be retention in ECF of large volumes of isotonic fluid, isotonic, okay, and do not contain sodium. For example, when we give the patient mannitol. Or it could be pseudo hyponatremia. Pseudo hyponatremia is called when it's a lab artifact seen with severe hyperlipidemia or paraproteinemia or even increased glucose levels. Understand? So now these are the causes of hyponatremia. One more thing, when there is hyperosmolality. So hyponatremia with hyperosmolality. Now, uh, see, extra osmoles in ECF draw water out of cell, diluting the sodium in ECF. So this could be the case. Or usually glucose, like rarely hypertonic mannitol. So usually glucose, because the glucose is too much in there, and the glucose is the one which is drawing too much water, and the water is causing a dilution effect, and we are getting hyponatremia. So this is important. And see, you can every 10 millimole per liter increase in blood glucose results 3 millimole per liter decrease in sodium. So it can occur in conditions like diabetes, diabetic ketoacidosis or diabetic coma, hyperosmolar state. If you will come over here, like when there is hyponatremia with hypoosmolality, what is there? The most common cause of hyponatremia is this one. So excess water in relation to sodium stores, which can be decreased, normal, or increased. So what we have to do clinically, okay, how we check like either the patient is having hypervolemia, eovolemic, or hypovolemic. See, a person who is hypovolemic, you will found that their urine output can maybe very less. Okay, you will found uh, in these patients in hypervolemia that hypovolemia, sorry, we are talking about. So in hypovolemia, their urine output will be decreased, as well as their body weight will be decreased because they have less body water. uh, we check skin turgor, okay, so that will be reduced. We check the blood pressure, that will be reduced. We check the jvp, that will be decreased, and we check the capillary refilling time, that will be increased. Hypervolemia, of course, these are the patients in which their weight will be increased, their body weight will be increased, their urine output can be normal or can be high. They may have edema, okay, their blood pressure will be raised or could be normal, and their skin turgor will be normal, okay. This thing, and eovolemia is the normal people. So see, whenever it is due to hypervolemia, hypervolemic, hypoosmolar, hyponatremia, what can be the causes? It could be congestive heart failure, it could be cirrhosis or ascites, nephrotic syndrome, or pregnancy. So see, normally when there is hyponatremia with hypoosmolality, so ideally if the kidneys are functioning fine, so they should be retaining sodium. So see, the urine sodium is basically less than 20. So it means like the kidneys are working fine. So these are the causes. But if the kidneys, in this case, when the kidneys should be retaining sodium, instead of retaining, they are still losing. So it means that they have acute kidney injury. If you will come over here, the hypovolemic, hypoosmolar hyponatremia type, again, see, we are checking the sodium. Okay, so in this case, if the kidneys, which should be retaining sodium, but they are losing sodium, so what it means, which what can be there? Maybe the patient is taking diuretic. So what diuretics will do? Diuretics, because their function is to throw sodium out, so whatever in the body is going on hyponatremia, still they are going to throw out more and more sodium. Uh, there is other condition in which the kidneys are retaining sodium, so it could be diarrhea. So in diarrhea, we can lose a lot of water as well as a lot of sodium, excessive sweating, or third spacing of the fluid inside the body, like peritonitis or this thing. And the middle condition, in which like there is eovolemia, Guys, remember a very important thing, that is syndrome of inappropriate release of ADH. Okay. Now, this is a condition in which the ADH is released no matter what's the condition of the sodium and the osmolality is there. So it keep on, they will keep on secreting. There are many causes of syndrome of inappropriate release of ADH, like it could be drugs, it could be many other things like head trauma and things like this. Okay, so in this case, we check the urine osmolality. So urine osmolality is more than 100. In this one, when the urine osmolality is less than 100, and there is hyposmolality and the urine osmolality is less than 100, so maybe it is psychogenic polydipsia. What it means, like someone who keep on drinking water, keep on drinking water, keep on drinking water. So what water will do, there will be a dilutional effect. Okay, there will be hyposmolar hyponatremia with eovolemic type, right? So these are the causes of hyponatremia. And now remember, whenever there is hyponatremia, uh, a very important factor is, like, we see like how much is the degree of hyponatremia. And one of the thing we always see, like, how fast hyponatremia occurs. Because if hyponatremia will occur slowly, maybe you will not find any clinical sign or symptoms. But if the hyponatremia is occurring fast, so there will be, because the body cells can accommodate the change if it is going to be slowly. But if the progression is fast, the body don't have time to accommodate that. So what will happen in hyponatremia? I explain you this thing. Whenever there is hyponatremia, okay, so there will be swelling of the cells. Okay, hyponatremia will cause swelling of the cells. Why? Because the water will shift in ICF inside the cell. Okay, so simply, uh, the cells are swollen in the body, right? So acute hyponatremia we call when they have uh, the hyponatremia which develops within less than 24 hours, 24 to 48 hours. And chronic hyponatremia is considered when it is developed over the period of 2 days or more than that. So in acute hyponatremia, they present with sign and symptoms, whereas in acute hyponatremia, they will be asymptomatic most of the time. Whereas in chronic hyponatremia, because there is adaptation by the cells, and especially in uh, one thing, guys, whenever it is sodium ions or sodium electrolytes, think about the brain. And whenever it is about potassium, think about the heart. So in this case, what happens when the patients, they are developing hyponatremia, so the cells are swelling up. So what happens, like, there is adaptation, like the brain, especially what it does, it normalize the brain volume through the loss of cellular electrolytes within hours and organic osmolytes within days. Okay, so there is some adaptive measures. But if it is acute type of hyponatremia, they can develop cerebral edema. So they present with headache, nausea, malaise, lethargy, cramps, anorexia, disorientation, and decreased level of consciousness, right? And they may develop seizures, coma, respiratory arrest, brain damage, brain stem damage, herniation, or even death. Okay. Now, guys, uh, the important thing over here, um, whenever someone have acute hyponatremia or chronic hyponatremia, whenever we treat it, okay, whenever we treat it slowly. Why? If we will treat it fast, so the cells which were swollen are going to shrink quickly, and the body don't have any time for accommodation. And simply what will happen, that there will be consequences, or there will be clinical signs and symptoms. Okay. uh, so that's why, first of all, we treat the underlying cause, of course, whatever is there. And the second thing is, of course, to bring the electrolyte levels normally. So what we do most of the time, we restrict the water, because see, the dilution is going on. We restrict the water intake. So when we restrict the patient from taking water, the person will keep on losing water, but he's not taking enough water. So this dilutional effect will be gone, and the sodium levels are going to come back normal, and osmolality is going to come back normal. But in that time, we keep on checking the serum sodium levels, we keep on checking the osmolality of the plasma, we keep on checking urine sodium as well as urine osmolality, right? So so we always what you can say, correct it slowly. Okay, so this is how what we do. So uh, I told you uh, acute and chronic, right? Now many patients who are symptomatic or they have acute hyponatremia, we can give them, you can say, a concentrated saline, like 3%, 0.9% normal saline is considered as the isotonic one. So we can give them 3% normal saline, okay, uh, to these patients. So this is like how we treat that. And of course, like if someone is developing severe symptoms like seizures or decreased level of consciousness, then we can treat it with sodium around, you can say, uh, by giving 3% normal saline to the patient, okay, with furosemide. So this is how we treat these patients. And I told you, like, one of the things is syndrome of inappropriate release of ADH, okay, or you can say syndrome of inappropriate antidiuretic hormone secretion. And what is there? See, they have hyponatremia with hypoosmolality, but the urine osmolality is more, as well as the urine sodium will be more as well. So it could be normal, it could be normal means, like, of course it will be more than 20 simply, okay, more than 20 to 40 millimole per liter. So there are different causes for this thing, like, it can occur as a paraneoplastic syndrome in small cell carcinoma. It can occur in Hodgkin lymphoma. It can occur in trauma of the CNS. It can occur in stroke. It can occur as a side effect of different drugs like antidepressants, like anti-cancer drugs, or chemotherapeutic drugs like cyclophosphamide, and many things, many causes are there of SIADH. Okay, so these things are the one which are important one. So remember this thing: hyponatremia can be chronic, or hyponatremia can be severe, right? Sorry, hyponatremia can be acute, or hyponatremia can be chronic. Okay, so acute one is usually with symptoms, but chronic one is usually without symptoms, because there is adaptation by the brain. Next is hypernatremia, right? So hypernatremia. Now, hypernatremia is quite easy as compared to hyponatremia. Uh, Hypernatremia. So, what's going on in hypernatremia, guys? Uh, the sodium level is increased, right? So, when the sodium level is increased, uh, of course, like, the ESF will be increased as well, or it could be a concentration of the sodium. So what we can say, when the patient have hypernatremia, simply when their sodium ions is more than 145 millimole per liter. So remember, hypernatremia is always a hyperosmolar state. Okay, because see the sodium ions are more. So simply uh, it is most of the time, or always, you can say, a hyperosmolar state. Now, why hypernatremia is there? Now, see, if I will take a glass and I will add salt in it, okay, and after that, of course, like, the osmolality of that solution, say, is like plasma, like 290 milliosmol per kg. But what will happen if I will take out just pure water? I will not take out any salt molecules, I will just take out water. So the remaining solution will become concentrated, right? So this is what happens in this one. Hypernatremia most of the time occurs either due to reduced intake or increased losses. So whenever it is due to reduced intake, so like elderly people who are bed bound and they are drinking less water, so they keep on losing, we lose water every day, by sweating, by our breathing. Infants coma or due to surgeries. And when what are the cases in which there is increased losses? So there is increased losses and you are not taking adequate intake. For example, in diarrhea, in fistulas, during exercise, during seizures. You lose water, but you don't lose much salt. Or renal losses are there, like central diabetes insipidus. What is central diabetes insipidus, or what is peripheral or nephrogenic diabetes insipidus? Like simply when the ADH, either it's absent or ADH is not acting. So what is the function of ADH? It is the one which retains the sodium as well as water. So what will happen when ADH is not there? We are going to lose more and more water. Remember, ADH is antidiuretic hormone. So it is the one which basically prevent diuresis, prevent the water loss. Or if you are giving the patient some osmotic diuresis, like drugs which are causing osmotic diuresis. Okay, hyperglycemia, glycemia is one of the example, or mannitol, or urea, or anything like this, right? So this is the causes of hypernatremia. Uh, Simply, guys, hypernatremia uh, have the same story whenever the hypernatremia is acute. So what happens in hypernatremia? See, water moves out of the cell, right? So the cells will shrink. So again, now whenever the hypernatremia is acute, so the body doesn't get any time for adaptation, so the patient will become symptomatic. But if the hypernatremia is slowly going, so what will happen, that the cells or the body can adapt to the changes. So what is happening? Cell shrinkage is happening. And what I told you, whenever it is sodium ions, think about brain. So what happens, like the brain cell becomes shrink, and they have altered mental status, they have weakness, they have neuromuscular irritability, they may have seizures, they may have comas, they may have death. Okay, so that's why it is important. And how we treat these patients? See, either we are having increased losses or reduced intake. What should be the treatment? Give them oral or IV free water. Okay, but don't correct it too rapidly. Why? If you are going to correct it too rapidly, it is going to cause problem again. Okay, so that's why correct it slowly. Okay, and uh, you can say one of the thing they tell us is like correct the serum sodium in hypernatremia. Correction of the serum sodium in hypernatremia should not increase or exceed 12 millimole per liter per 24 hours. What it means, like someone who have hypernatremia, their value is like 160, so you should not bring it at 140 within 24 hours. Rather, it should be less than, or it should be higher than 148 at the end of 24 hours. Okay, so this thing is the thing we have. This is how we treat. We encourage the patient to drink pure water if they can take it by orally. Okay, and if we have to give IV, if the patient cannot take per oral fluid, many patients they cannot take. For example, infant they cannot take, surgical patients they cannot take, coma patients cannot take, elderly like who have swallowing difficulty or stroke, they cannot take. So in that them we give them hypotonic IV fluids, like um, half normal saline. Like normal saline is 0.9% normal saline, we will give them 0.45% normal saline. So we are going to give them hypotonic fluid. And one of the rule is like to give them 2 ml per kg per hour of free water. Okay, uh, you can say to correct the sodium by zero point 0.5 millimole per liter per hour. Okay, so this is like see, if you will correct 0.5 in 1 hour. So in 24 hours, you are going to correct how much? 12 millimole. Okay. So simply give them 2 ml per kg per hour of free water, and it is going to correct zero point 0.5 millimole per liter of sodium every hour. Okay, so this is how we do this thing. So thank you so much, guys. In the next lecture, we will talk about potassium and other ions.